Good morning to all. My name is David Kanarak. I work at MGH in the Pulmonary and Critical Care Unit. It's my pleasure to welcome everybody who's online, welcome those who are offline as well, to this, which is, to our very best calculation, is about our 50th annual course in pulmonary and critical care medicine. We're not quite sure when it started. We hope that we will be able to provide you with some additional information, direction. The speakers are pretty much all, with a few exceptions, from our unit. They are, as a group, wonderful to work with. They are ambitious, driven, very nice people, very keen to advance the field of pulmonary and critical care medicine. The subjects which we have chosen largely come from requests from people who've been on previous courses. We will give you at the end of this, you will get a questionnaire. We very much rely on the information that we get from you, critical, praiseworthy, what you like, what you don't like, what you think we've missed on, and what you would like emphasized or prefer to see emphasized in the future. The speakers themselves are ready and waiting to go. It's been a transition. Originally in this course was, of course, always in person, and now we have switched to the virtual form. It's been made life much easier, easy to round up your speakers, get the discussions going. So I hope you will enjoy this course. We will take the questions on each talk as we go along, and you will submit them, and we'll give the answers the best we can. So with that said, I would really like to welcome all the people who are online, waiting to listen to wise words, we hope, and welcome you all here. Thank you. So we'll wait now until we're ready to give all the talks, which will occur at 8 o'clock, and I will be the first speaker. So, good morning to you all. Again, I spoke to you 15 minutes ago. I'm going to try and deal as best I can with the problem of gastroesophageal reflux and its pulmonary consequences. It's an ongoing problem. We have at MGH in the pulmonary unit every Friday, we have what we call lung lunch. Fridays from 12 to 1, where people bring cases and we discuss the cases. Inevitably, somebody shows a case with various history and physical exam, not so much anymore, but a CT scan which shows either some ground glass nodules, some more solid nodules, some bigger areas of involvement, and a discussion begins about what is causing this. And as the discussion goes on, and there is really no absolute answer, sooner or later, somebody says, maybe she's aspirating. And there are a lot of wise heads nod, and this discussion ends there. Maybe she's aspirating, because nobody can quite figure out, how do you prove that? How do you know that this is reflux? What's the test you would use? How accurate are the tests? What alternatives do we have? What do we do now? This has been going on for a long, long time. So I'd like to talk a little bit about this whole problem of gastroesophageal reflux, aspiration. What tests do we have? How can we prove that there's been aspiration? And so on. So why is this subject so controversial? The subject of gastroesophageal reflux disease, so controversial. It's controversial because it involves many potential diseases. There are many diseases in which GERD is contributory, causative, and there are many different clinical presentations, whether it be a cough or asthma, pneumonia. The problem is largely that there's no accepted definite test for aspiration. Perhaps the only thing that people would accept is if you have a bronchoscopy and pull out some vegetable fibers. And how does this disease develop? What are we talking about here? Reflux. Perhaps we could begin with the mechanism of disease development. There are probably two key mechanisms that are discussed. Mostly, the one mechanism is that there is a column of gastric acid and whatever else happens to be in the stomach, which comes up to the esophagus and then is delivered to various areas in the lung, mostly around the larynx, and either something is aspirated or simply an inflammatory process goes on. But there is another school of thought which believes that there is also an aerosol that is delivered. And the aerosol is thought to come from the air that you see on a CT scan in the stomach, that's where the air comes from, and that the aerosol then gets delivered and goes much higher than the stream of fluid, that in fact it goes up into the sinuses, which is why you sometimes get sinusitis involved. Even into the middle ear it's been found. How do you prove each of these? That's difficult. Nobody has really proven, but we will get to that soon, the aerosol theory, nor is the stream of liquid easily accepted as and proven. So there are a number of reasons then why GERD is so controversial. We'll go through the diseases, clinical presentations, pathology, the tests that are available or not available, and the mechanism of disease development. So the disease briefly, and you can make this list longer, but this is probably a reasonable list of diseases which occur and which we then try to consider as a mechanism of exacerbation or cause. A list of diseases. You could divide them into acute and chronic. Under acute, we would say ARDS, asthma, the foreign body, obviously pneumonia, COPD exacerbation. Under chronic, the ILD has long been thought to be caused by the aspiration of perhaps acid, but aspiration at any rate, lipoid pneumonias, bronchiectasis, bronchitis, and the bronchitis of obliterative syndrome. So it comes in many forms, and in each of these, aspiration, as a consequence of of GERD, gastroesophageal reflux, or if you're an aerosol fan, aerosol listed as the cause. Well, if you the pathology, what we often do, of course, in medicine is we try and get a piece of pathology and look at it under a microscope and make a diagnosis. The problem is that aspiration pathology changes depending upon what's aspirated. So, for example, and some of this, of course, is from real life, some of it is experimental. If you just put a large volume of acid in, get an acute pneumonitis. If you add some food particles, it becomes much more severe injury. If you take the food particles, but you put them in with a liquid of a neutral pH, it's nodular disease. It's not acute pneumonitis any longer. Or it could be granulomas, could be even giant cells. Bronchiolitis obliterans with organizing pneumonia, boop. And maybe if it's non-acid reflux, some people believe it's fibrosis. So the pathology doesn't really help you. You can have many different pictures. For example, here is one which has a granuloma in with a large multinucleate cell and lots of inflammation around it. Here is another one with multiple, much smaller nodules, none of that acute inflammation, no giant cells, a very different pathological picture, but also finally known to be due to aspiration. Then there's the problem of whether healthy people aspirate. How common is this process? So in a prospective trial of healthy volunteers, while they were sleeping, they delivered 2 cc's per hour, a slow drip of a radioactive colloid solution into their mouths while they were sleeping. And 50% of them had uptake of the isotope within their lungs. So we're aspirating all the time. Why don't we get sick? That's another question. Presumably because it's not very pathological substance that we're aspirating, but aspiration goes on all the time. What tests do we have for this? I've listed some of them that have been tried. None have been proven to be of value. So first of all, there's the isotope meal. What you do in the isotope meal is you give them some food in which you have mixed up some isotope, tell them to go to sleep, and scan the lung the next morning for isotope. The problem with that is it's very hard to actually carry out that process. Every now and again, somebody publish a case report where they have said we start with an isotope meal and showed that this person was aspirating. In actual fact, it's a difficult test to do. We have not managed to complete a study at MGH. In fact, the nuclear medicine people won't even do the test anymore. And the reason is that the isotope meal many, many times just moves on in the stomach as a sort of ball of food with isotope mixed up with it. It just moves on. We've got dietitians involved, we've mixed fat and all sorts of things to keep the isotope meal in the stomach, but found it very difficult to do so, to the point where they just laugh at me over in the nuclear medicine department and say, David, we're not trying again. We've done it before. We can't make it work. Then there's what's called another popular test. These are all tests that have been tried, with the so-called lipid-laden macrophage index. This is a lipid-laden macrophage, what we're talking about. The index of these tests is done by staining an aspirate and counting up how many cells, macrophages, have lipid within them, and from 1 to 4 and expressing it as an index. It's not that difficult to find these lipid-laden macrophages, which is the problem. The lipid-laden macrophage index is very non-specific. The picture I showed you was actually from a case of vaping. It's not, it was thought at one point to be quite specific for aspiration. But since then, it's been found to be a feature of almost any kind of acute process in the lung and non-specific for aspiration. It was used a lot longer in pediatrics, but they too have now given up on this index. I suppose there's still some people that use it, but it really is a feature of almost any acute process. The person who first described it came to speak at our course once. And I asked him, do you still use the lipid-laden macrophage index? And he said, no, I don't use it anymore. It's just a feature of an acute illness. So that didn't help. The next concept was that if you are aspirating something, the best way you could prove that it was reflux from the stomach would be to find something in your bronchopulmonary aspirate that can only come from the stomach. So bile salt might be one thing. Pepsin might be another. I have tried the pepsin one on many occasions and finally gave it up. We never, ever found any pepsin. We sent it to outside lab and they didn't find pepsin. So maybe sometimes you'll find it, and we'll get to pepsin later because it is an important factor. Bile salts would test around. You don't read articles, you don't see any of these things described anymore because they were just not specific enough or too difficult to find, or you couldn't find the substance in cases which looked highly likely to be reflux with aspiration. I put an intratracheal pH. Somebody once did a study in which they put a pH catheter into the trachea and monitored away, and were looking for fall in pH. And again, they couldn't keep it there, and they couldn't know when the person was likely to be aspirating, and it was never fully tested and has not really been used. The pepsin story is an interesting one. As pepsin comes up, pepsin is a real possibility. Pepsin itself comes up together with the hydrochloric acid. Pepsin is produced by the intragastric cells at the same time as acid is produced. Acid itself comes up and under low pH circumstances inactivates the pepsin, though the pepsin is still there. As the refluxate comes up the esophagus, the pepsin comes up with it. Ultimately, as it goes high enough, if it goes high enough to reach the larynx, the pepsin is deposited, inactivated on the larynx. The ENT doctors are very sure that pepsin is a large part of the problem. The pepsin itself is then endocytosed. This is the theory with a lot of proof behind it. The pepsin is endocytosed into the acid milieu of the larynx and then becomes active and causes an inflammatory process. That is the mechanism of formation of the inflammatory process within the, and presents with cough or wheezing, or particularly voice change. pepsin itself can be detected directly, but pepsin itself is thought to be the cause of the process. So the pepsin is not inactivated. It's not destroyed by acid. It is inactivated by what's called an alginate. An alginate is a substance that comes from seaweed, and there are now several products on the market. Nothing to do with me, which contain seaweed, and which the ENT people, because of their insistence that a large part of the problem they deal with is due to pepsin, have produced several foods or sources that inactivate the pepsin and contain the alginate. There are two products, I have no interest in them, which are used. One is in an attempt, one is, funnily enough, called Reflux Gourmet, which is popular here in Boston. And the other one is Gaviscon Advance. Gaviscon Advance contains an alginate derived from seaweed, and it is claimed that it is very helpful in taking out LV, which is LPR, those patients, and it is added to their prescription whenever that is thought that they have LPR. Whether it really works or makes a difference is unclear. So your diagnostic test, one, you can look for stuff that should only come up from the stomach: bile salts, pepsin, lipid-laden macrophage index, and the azotate meal, but none of those diagnostic tests are easy to use. Looking for pepsin is turning out to be perhaps the more important test. There is now a test which has only been available in England or perhaps in Europe, where called a PEP test. The PEP test looks for pepsin in the saliva and is particularly favored, of course, by people who believe in an aerosol, but there's no reason why it couldn't go up higher. I was looking to prepare this, as I do every year, to see whether we have the PEP test available in the United States, and lo and behold, in the last couple of weeks, the company has decided to produce it. So we may have the PEP test available to us reasonably soon. As I said, it's an antibody test for pepsin in the saliva, and would presumably give good support to the fact that the symptoms you are dealing with are in fact due to reflux, because ultimately pepsin is only produced in the stomach. So what about gastroesophageal reflux, the disease itself? It was defined a long time ago as being symptoms or complications resulting from the reflux of gastric contents into the esophagus or beyond, into the oral cavity or the larynx or the lung. So actually the original one only said into the esophagus, but subsequent definitions recognized that the reflux could go into the oral cavity, The mechanisms for this are thought to be the mechanisms for permitting reflux could be a reflex, such as in the lower esophagus and producing asthma, presumably by stimulating the vagus nerve, or in the upper esophagus. It's an irritative system with a cough. There could be direct damage, for example, in the larynx, such as LPR, laryngopharyngeal reflux, laryngospasm, voice change. You require aspiration to go higher than that, it has to go above the upper esophageal sphincter. And that itself is required for parenchymal pathology, obviously. And then we have to consider thoracic and abdominal pressure changes. Let's talk about that a little bit, because I actually think that's quite important. The diaphragm crura occur at the same level as the lower esophageal sphincter. It's a nice double method of limiting reflux. But those two can be separated. For example, if you have a hiatal hernia, which is maybe the most common way, the abdominal crura move away from the lower esophageal sphincter. The pressure they can exert, the two together can exert to limit thoracic flow into the abdominal flow into the thorax is much lower, and hence can permit aspiration and reflux. When do these happen? Well, the common one, of course, is the hiatal hernia, where the two are clearly separated. But I think there are other situations where it happens as well without being quite as obvious. For example, hyperinflation of the lung, which will push down on the diaphragms. You can see the flat diaphragms clearly moved away from their original position. Abdominal pressure increases. Ascites would be an example, would move the diaphragm upwards. So once those two are separated, you have a marked decrease in the pressure that they can produce and the limitation of reflux. I myself have a habit of always looking for hiatal hernia in situations where you can postulate that reflux is possible. You have a number of defenses against aspiration: swallowing, epiglottis, vocal cord closure, upper and lower sphincters, as you go there, peristalsis. We've talked about the crural diaphragm plus the lower sphincter, and cough itself, which will clear the lungs, a mucociliary barrier, and innate immunity. So how do you link these things, reflux, and how do you link it to aspiration? My view, since we lack a nice test to show that this person is aspirating, unless you're lucky enough to find peptide in your bronchoalveolar lavage. I've tried it so many times, I've given up for finding it in that. Is a compatible history, compatible imaging, and finally compatible pathology. I think these are the ways in your mind to link these things. So the history is the important history for your patients are recurrent symptoms or a recurrent disease, whether that is, for example, if you regard symptom might be recurrent coughing, recurrent disease might be, if it is simple, it could be pneumonia, I suppose, or asthma. It's a disease that's recurrent. which can be known to be associated with GERD. So the most important thing is recurrent symptoms, recurrent disease. You can document aspiration in several ways, but the problem is on CT scan, there are many different features on a CT scan, which, as you well know, how many times you get a CT report which says this could be aspiration. So there are many different features on a CT scan which will raise the diagnosis. Hiatus hernia, migratory changes. One day you have multifocal ground glass changes in one area, and then there is the next time the patient comes in, multifocal ground glass changes, but somewhere else. That almost surely would raise the possibility. Another one is poorly defined centrilobular nodules. These centrilobular nodules are usually occur within a few millimeters of the pleura or of the fissures. You can see many of them. A dilated esophagus would raise your suspicion, but sometimes a mass or consolidation can be like that. And tree and bud changes, which by implication means that your bronchioles are involved. And that's where one of the places aspirate might go. So there are many different features on the CT which might raise it in your mind. Another one might be disease which occurs in one lung. So rather than multifocal disease might raise your suspicion as well. There, for example, is an example of a single, but I thought it was a good picture, of centrilobular nodule, and a few on the other side as well. Those are centrilobular nodules with some subpleural sparing. So how might you document this? Well, the bronchoscopy would be great. Vegetable matter is the ultimate. Hardly ever happens. And it's never happened in my world. It is known that non-tubercular mycobacteria are or can be associated with aspiration, but that's not a very specific test. What we often do when we have infiltrates, we're not sure what they're composed of. You can do a VATS or a transbronchial biopsy the lung of some way or other that you choose. Problem is, in aspiration, you can see granulomas, you can see giant cells, lipoid nodules, organizing pneumonia, or very acute pneumonitis. So that the pathology very often doesn't help you, just confirms what you already knew, that aspiration could present in the manner that is being described and for which you are doing a biopsy. Show you a few cases. This was a cardiac catheterization on a 54-year-old police officer with dyspnea. Showed triple vessel disease. They wanted to operate on them, but they did a preoperative chest x-ray, and the x-ray showed basal infiltrates. He actually had no symptoms of GERD. Silent aspiration, if that's what it was, that's what the CT showed. Bilateral disease, some centrilobular nodules, both lungs, and in a position which could easily be organizing pneumonia as well. I happened to look at this, thought that aspiration could easily explain this posterior infiltrate. We did a barium swallow, which showed reflux right the way up to the thoracic inlet. This man had no symptoms of reflux. He didn't have heartburn or regurgitation. A biopsy showed BOOP, and he had complete resolution, followed a course of steroids. Now, you might ask, how do you know that this was aspiration? Of course, we don't. Perhaps he ate something one day and he forgot about it. But he had reflux all the way up to the thoracic limb. So I think it's very, very likely that this man aspirated due to reflux. But these questions always come up because we have no absolute diagnostic feature. But this would be a fairly easy one. How about this one? A 65-year-old RN had repeated admissions for recurrent severe dyspnea with infiltrates. Now, she actually would go to the ED of a hospital close to ours. The physicians who were asked to see her there were all pulmonologists, and all of them, everyone who made these diagnoses, had been fellows in our unit. Perhaps it was me that didn't teach them. They had multiple diagnoses: hypersensitivity pneumonitis, chronic eosinophilic pneumonia. All these different diagnoses were raised. These are some of the studies that she had. She had an echo, cardiac catheterization, CT, CTA, bronchoscopy, transbronchial biopsy. You can imagine the lab studies that she had. These were done, these evaluations were done by physicians whom I knew well, who were good doctors and could be my doctor any day of the week. Yet this is what they kept concluding. When she came to see me, she was on high-dose steroids, Cushingoid, obese, in a wheelchair. We did a barium swallow. She had spontaneous reflux all the way to the clavicles. She had a Roux-en-Y, lost 110 pounds, and walks unassisted to come in and visit me every now and again. I show you these cases to show you that this patient had recurrent problems. They had no specific diagnosis. They did all the things they thought they should do. Very good doctors can miss these diagnoses. So what symptoms should raise your suspicion? Cough, wheeze, pulmonary symptoms, dyspnea, chest pain, throat clearing, hoarseness, something that goes up into the throat and may well represent laryngopharyngeal thrombitis. It may present as asthma, it may present as COPD exacerbations. Acid gets in there, acid gets in for the asthma. Acid simply stimulates a reflux. Interstitial lung disease is a favorite one. Recurrent pneumonia, all the nodules that we're asked to talk about, maybe, and in transplantation. So the message is to think GERD with any recurrent process. Diagnosis, it depends on heartburn, regurgitation, sensitivity of these symptoms is fair, but not good, and the specificity is variable. A response to PPI therapy, proton pulse inhibitors, that would, of course, make a good case for it. A barium swallow, if it's very specific, yes. Some people have used ambulatory pH, endoscopy. Many of these only assess the risk of aspiration, however. They don't tell you that the person is actually aspirating. There are many diseases, COPD listed here, interstitial lung disease, connective tissue disease, lung transplantation, cystic fibrosis, which must be thought about. COPD and GERD, there's a high prevalence of GERD in COPD, significant association between GERD symptoms and COPD exacerbations. In one study, they showed a drop in esophageal pH corresponded with drops in O2 saturation in 6 out of 15 patients who were known to have reflux and COPD. In IPF, there's a high prevalence of GERD. Proximal GERD in 30 to 70%, and distal GERD in most of them. It would fit the picture of an aberrant fibroblast proliferation due to recurrent epithelial injury. That's a theory of the formation of IPF. Could intermittent microaspiration due to reflux be that stimulus? Sure. Could more severe exacerbations be the cause of the acute exacerbation? Sure. Could GERD play the role in the chronic cough? GERD medication use in IPF has been associated with a lower fibrosis score and predicted a longer survival time by a long time, but this was never confirmed. 1967 days versus 896 days. That's a big difference. But asymmetric IPF should raise your suspicion much higher. There's a high prevalence of symptomatic GERD in asymmetric IPF. IPF in one lung much more than the other. It's been shown to be more extensive fibrosis-dependent lung when sleeping, and acute exacerbations occur more frequently in the asymmetric lung as judged by HRCT. Now, should they all be treated for GERD? It's weak, but in conflicted recommendation, the ATS guidelines, PPIs are cheap and have limited side effects. On the other hand, in the Impulsus and pirfenidone trials, GERD therapy had no effect. Does the microbiome get altered? Another question. Is it pepsin? Is it bile salts? What is actually doing it? Or is it infection that's causing the progressive fibrosis? They tried to settle this with the REP IPF trial. 58 patients with IPF and gastroesophageal reflux were randomized to fundoplication and controls. There was no statistical difference at the end of the study, but the study had to be discontinued because there were insufficient patients to do fundoplication, including in the controls. But if you look at the actual study in the Lancet, there were fewer events and deaths, fewer acute exacerbations, fewer deaths, fewer respiratory hospitalizations in the group that got fundoplication. But I emphasize that this was not statistically significant. You see it in connective tissue diseases and GERD, which are related to systemic sclerosis. The prevalence of GERD in some of these things is you see, and there's frequent dysmotility in systemic sclerosis. Cough may be the most common cause of cough. GERD symptoms, however, are absent in about 40 patients. Maybe due to laryngopharyngeal reflux. It could be due to the aerosol aspiration, many mechanisms. Barium swallow is often negative when you're trying to figure out why a person is coughing. The level of pepsin does not correlate with frequency. And perhaps cough is just a protective mechanism. Lung transplants increase GERD prevalence, maybe because of the gastroparesis, maybe vagal injury during the surgery. And in CF and GERD, its prevalence in 3 studies was of CF showed that GERD was present in 80 to 91%. It's maybe gastroparesis. A 57-year-old woman they were sent to see me. Her son was a very good physician working in the hospital. She had difficult to control asthma. She was treated with all the usual substances. She had marked symptoms of GERD. Intensive GERD medical therapy had no influence on her asthma, carried on for over years. But a Nissen fundoplication dramatically alleviated her asthma. So you can't even use your therapy to work. It's a potential trigger. It's common in asthma, and respiratory symptoms are common in GERD. Some trials have shown improvement in asthma, but the results are very inconsistent. The clues that you should look for are asthma symptoms during the symptoms of reflux, perhaps nocturnal asthma, but that is not uncommon anyway. Exercise-induced asthma, symptoms with some foods, and symptomatic GERD. You need to continue the high-dose PPIs. You need to continue the PPIs for many, many months before you decide it's not working. And sometimes you need to do surgery. Weight loss, elevate the head of the bed. avoid meals 3 to 4 hours before bedtime, and PPIs for at least 8 weeks, but I think for longer. So the GERD and its relationship to reflux is a real problem. I've tried to define it. Remember about recurrent disease being the most important issue that should raise your suspicion of that disease. And we may have a new test in the United States now, the PEP test. I have no idea what that's going to show us. Thank you very much.